On behalf of the American Heart Association and No Diabetes by Heart, I would like to welcome you to today's webinar, No Diabetes by Heart Presents, the Link Between Diabetes and Coronary Artery Disease. My name is Renee Sednu, and I am a Program Development Manager for Quality Outcomes Research and Analytics at the American Heart Association. I'm joined by my AHA Quality Outcomes Research and Analytics colleague, Jeannie Rash. Before we begin, I'd like to quickly review how to use this webinar platform for today's event. If you'd like a copy of today's presentation, you can download a PDF in the handout section of your attendee control panel. If you experience any technical difficulties, most user issues can be resolved by refreshing your browser. If that does not work, please contact the GoToWebinar customer service team found in your confirmation and reminder email. If you require live captioning services during the webinar, please visit the link in the audience chat. And you can view on the chat from your control panel. You may need to click the down arrow to see the content. At the conclusion of today's presentation, you will receive a link to access the recording, as well as an invitation to complete our feedback survey. You will have the opportunity to submit text questions to today's presenters in the questions section, and you can submit these questions at any time, and we'll review them during the Q&A at the end of the presentation as time permits. We will also answer any questions by text that we can during the presentation. We will begin today's program with a brief overview of the No Diabetes by Heart initiative and the Target Type 2 Diabetes Recognition Program. Then we will welcome guest speaker Dr. Tracy Wang for her presentation, Diabetes and Cardiovascular Disease, Making an Impact. We'll then take some time to review the recent changes to Get With the Guidelines Coronary Artery Disease, CAD data elements, and reports related to diabetes care. As a reminder, these changes were made in December of 2021 and reviewed during a webinar held on December 1st. And distributed via the Get With the Guidelines CAD release notes also in December. And we have a link to that recording in the slide deck as well. And feel free to contact your local Get With the Guidelines representative or myself. My contact information, renee.sednu@heart.org, is in your confirmation email if you have any questions. Finally, we'll end with a Q&A. So an overview for today, I think many of you know part of this call, cardiovascular disease is the leading cause of death and a major cause of heart attacks, strokes, and disability for people living with type 2 diabetes. The American Heart Association and the American Diabetes Association, along with industry leaders, have proudly launched the groundbreaking collaborative initiative known as No Diabetes by Heart, to reduce cardiovascular disease, deaths, heart attacks, and strokes in people living with type 2 diabetes. The No Diabetes by Heart initiative supports quality improvement efforts by engaging directly with hospitals and outpatient clinics to provide long-term support to their teams of professionals as they redesign healthcare to better serve patients with both diabetes and cardiovascular disease. AHA's Target Type 2 Diabetes Honor Roll is a component of this broader initiative that aims to ensure patients with type 2 diabetes receive the most up-to-date evidence-based care. To bring attention to this critical high-risk population, American Heart Association has established the Target Type 2 Diabetes Honor Roll recognition opportunity, currently available for hospital participants of Get With the Guidelines Heart Failure and Get With the Guidelines Stroke. Hospitals that meet specific measure thresholds may be eligible for recognition in the Target Type 2 Diabetes Honor Roll alongside their existing awards. To learn more about this program, we encourage you to visit our Target Type 2 Diabetes Honor Roll website, shown at the bottom right hand of this slide, where you can also view additional resources. As well as we encourage you to visit nodiabetesbyheart.org for past webinars, podcasts, latest guidelines, and more. It is now my pleasure to introduce our distinguished speaker, Tracy Yu-Ping Wang. Dr. Wang is a professor of medicine and cardiology at Duke University. She received her MD from Harvard Medical School and also holds a Master's of Science degree in molecular biochemistry biophysics from Yale University and an MHS degree in clinical research from Duke University. Dr. Wang is a health services researcher with expertise in implementation science and pragmatic clinical trials. She has led several cardiovascular clinical trials and registries at the Duke Clinical Research Institute that have focused on comparative effectiveness and safety, health disparities, care quality assessment, and quality improvement. Dr. Wang currently chairs the Council Operations Committee at the American Heart Association and served as the chair of AHA's Quality of Care and Outcomes Research Council from 2017 to 2019, as well as many task force committees and writing groups for the American Heart Association, American College of Cardiology, and American College of Physicians. Most recently, she served on the steering committee for the AHA's COVID-19 Cardiovascular Disease Registry. She is an associate editor of the JAMA Internal Medicine Journal and is the director of health services and outcome research at the Duke Clinical Research Institute. Lastly, she actively practices as a non-invasive cardiology with both inpatient and outpatient responsibilities. Welcome, Dr. Wang. It's such a pleasure to have you. The floor is yours.
Thank you so very much, Renee. I hope you guys can all hear me well. I'm going to speak for the next 40 or so minutes on the topic of diabetes and cardiovascular disease. And let's get started. Let's go to the next slide. All right, some disclosures first. I do have research grants both from industry as well as foundational and governmental sources. And I do a little bit of consulting as well, as you can see on this slide here. I usually like to start my talk with a bit of a case. So this may sound familiar to you as you're taking care of patients or looking at medical charts. This is very similar to a patient that I saw just in rounding on service this last week. So this is a 76-year-old gentleman. He comes in with chest discomfort, shortness of breath, and was ultimately diagnosed with a non-ST elevation MI. He has a history of type 2 diabetes. He has hypertension. He lives alone. And he also had a bout of pancreatitis not too long ago. When he came into the hospital, his medications included metformin, ramipril, hydrochlorothiazide, and atorvastatin. And on exam on first admission, he was noted to be obese with a BMI of 30, slightly hypertensive, not atypical for someone presenting with a non-STEMI. Pulse was 72. And during his hospitalization, here are some labs. He's got an eGFR of 69. He's got an A1C of 8.6%, an LDL of 122, and a triglyceride of 124. And with his non-STEMI, he underwent a cardiac catheterization and was noted to have a mid-LAD lesion that was treated with a drug-eluting stent. His EF did take a little hit from this, and it was 40% at the end of his hospitalization. So this is the type of patient that we're confronted with quite frequently. I would say patients with diabetes probably make up at least a third, if not half, of the patients that we see in hospital with an acute MI. So let's talk about the prevalence of diabetes. Unfortunately, it is on the rise. As you can see, this is a timeline starting from the 1950s when we started to sample households to look at the prevalence of diabetes. And then going all the way, the slide is a little old now, but it goes all the way to 2006, and we have not seen this curve plateau out. In fact, if anything else, it looks like it's continuing to climb at a higher rate than in the early days of the survey. In part, this is because we've got an aging US population, and in part, I think many people know this, that we've got a growing number of overweight and physically inactive individuals that are all contributing to the higher prevalence of diabetes in our society here. Unfortunately, diabetes is kind of, a diagnosis of diabetes is kind of like the tip of the iceberg here, because we know that it does take several years in onset, and some folks think of that stage as a pre-diabetic stage. A diagnosis can often be made late, and sometimes, as many of you know, diagnoses of diabetes are made for hospitalizations that are often the result of complications of diabetes, like an MI. But even before diagnosis, many of the micro and macrovascular complications, as you can see on the slide, have already started. So one of the key things here with diabetes is early diagnosis, so that we can implement healthy lifestyle changes, as well as medication changes if needed, to try to stave off the complications related to diabetes. Because once patients develop diabetes, unfortunately, the risks climb to much higher levels. So this is a graphic looking at the risk of cardiovascular death. So this is typically death from either sudden cardiac death, or MI, or stroke, or heart failure, or other cardiovascular reasons. And what you see here are clusters of bars on the bottom. And you can see that CHD, CVD mortality really track in the same way. I want you to focus on the yellow bars. The yellow bars are those who are patients with diabetes. And then you focus on the blue bar, the light blue bar at the end. And those are the patients who have what I call the double whammy. They have diabetes and cardiovascular disease. You see this group of patients, they're more likely to die than if they had the red bar, which is just cardiovascular disease alone. But certainly having diabetes puts patients at much higher risk of cardiovascular death than the green bars, which are patients who are healthy with neither cardiovascular disease nor diabetes, or any risk factors such as metabolic syndrome that could predispose to these. So when we're talking about a very hard outcome like cardiovascular disease, we know that the risk is much higher in patients with diabetes. You combine that with cardiovascular disease and it really skyrockets here. So this is a very important risk factor to think about modifying here. When we look at distribution of mortality causes in patients with type 2 diabetes, we see that about half of these patients die a cardiovascular death. So it does make up a significant contribution to mortality in this population. And then on the right-hand side of the slide, what you see is a breakdown of cardiovascular death. And you find that the scary one, sudden cardiac death, makes up a good chunk of that. And then the ones that might be more treatable if we catch them in time, like acute MI, stroke, and heart failure, probably make up about a third of these cardiovascular deaths. And then there is another bucket of deaths that is sort of a miscellaneous group of patients here. So this is a group, again, emphasizing high cardiovascular risk. And these are data from the TCOS trial that are shown here on the slide. The duration of diabetes makes a difference. So this is the Nurses' Health Study, which looked at women aged 30 to 55 and followed them for 20 years. It's a large population of women. And on the very right-hand side of the slide, I'm going to have you pay attention to those two bars that I've circled in red here. That light gray bar on the right-hand side, these are patients with diabetes, but who've never had coronary artery disease before, but they've had diabetes for 15 plus years. And you compare that to the dark gray bar on the left side of the slide. These are patients without diabetes, but who've had cardiovascular disease. You see that the heights of these columns are quite similar, which basically says, even in the absence of coronary artery disease, if you have diabetes for 15 plus years, you're basically at the same risk of someone who doesn't have diabetes but has coronary artery disease. And now if you compare that to the last column on the right, you can see that if you combine these, so long duration of diabetes plus heart disease, then your relative risk of fatal cardiovascular disease is 30%. Pretty high here. Here's another slide related to life expectancy with diabetes. It's referenced to patients without diabetes. That's the very last row. But as you can see, just by having diabetes doubles your risk of having lower life expectancy. You add a cardiovascular disease condition to that, that doubles it again to about 4-fold hazard ratio here. And then if you've got diabetes, stroke, and have had a heart attack, you've now increased your risk 7-fold. So the amount of life to be expected in patients with diabetes is in fact much shorter, which is also the reason why we need to be very intensive with our prevention efforts for these patients. Okay, so risk of MI in patients with diabetes, and it really doesn't matter if you are a man or a woman. If you have diabetes, you go into the top 2 curves, which means your risk of MI is higher with diabetes, regardless of gender or sex, than if you did not have diabetes. Okay, so diabetes is a factor that's independent of gender. And then if you look comparing men versus women, currently we do see that men are at a higher risk of MI in an age-matched fashion than women, regardless of diabetes status as well. So the absolute risk of MI is higher in people with diabetes, and in an age-matched fashion is slightly higher for men than for women. And there are, of course, a number of reasons why diabetes can lead to coronary disease. In part, there's a proclivity towards thrombosis. In part, there are lots of risk factors that make the diagnosis worse. So dyslipidemia, insulin resistance, hyperglycemia. And then there are physiologic changes to the blood vessels, to the cells, that also predispose to progression of atherosclerotic disease here. So increased inflammatory markers on the left-hand side of the slide as well. So lots and lots of reasons for why diabetes can lead to coronary disease. And also, these are the targets of many of the novel therapies that we're thinking about to try to reduce risk in patients with diabetes. But first of all, trying to prevent diabetes would obviously be the most effective way to avoid all of this, which is why in my patients who are mostly primary prevention, I'm often very strongly encouraging lifestyle changes and dietary changes to try to reduce the risk of diabetes at all. Now, you're probably seeing a lot of patients who are in the hospital with an acute MI. And it may be a new diagnosis of diabetes or no prior diagnosis of diabetes or an old diagnosis of diabetes. And this is a very nice prospective observational study that looks at the risk of subsequent events in these patients. And clearly the patients with diabetes who've just had a heart attack do the worst compared to those who've not had diabetes nor an MI. So you can see each of these factors in and of themselves add risk to prognosis here. So now we're dealing with this group of patients at the lowest curve here, where the risk is actually quite high for for developing another event. So on the inpatient side, we are being, in many ways, the patient is a captive audience. But this is the time where we sort of try to get patients on the right track. So first is trying to come up with a diagnosis and detect it if it's there. So as I said, many patients can show up to their MI without knowing that they're diabetic. The MI is their heralding event. And so in these patients, the recommendation is to think about doing an A1C measurement if they've never been tested before, to help them understand what their risks are. And in patients who already have a diagnosis of diabetes, if they've not had an A1C measured in the last 3 months, we want to help them look at their glycemic control over the last 3 months to be able to counsel them on the next steps. In terms of intensity of in-hospital glycemic management, when someone's critically ill, so usually in the ICU setting, this is where a lot of times I'm seeing a lot of these patients, we tend to be a little bit looser with our treatment goal. We're not aiming for perfect control, but we're aiming for good control. So we want blood sugars that are in the range of 140 to 180. And as they transition to the general wards and are getting ready to hopefully approach discharge, we start tightening things up a little bit and trying to get them to a level that is tolerable, keeping in mind, though, that their diets in the hospital may be quite different from their diets outside of the hospital. So we do need to look at how well we can achieve these targets safely. And this is also always a good time to evaluate patients' lifestyle and provide counseling. If they don't have a habit of checking their blood sugars, we need to sort of inculcate that behavior into them. Remember, these patients are captive audiences in the hospital. They have nothing more to do than to listen to us nag them or teach them about things. So we try to leverage that. And most of them are receptive to this, especially in the setting of an acute MI. This is the time where I think a lot of patients are very motivated to understand how they can avoid another MI or another hospitalization. This is a good time to be thinking about what medications they should be on. And there have been a number of large randomized clinical trials that have compared ACE inhibitors to placebo in both the primary prevention setting as well as the secondary prevention setting. And most of these show a survival or a cardiovascular benefit to ACE inhibitors over placebo. These days, a lot of that data has also been translated to ARBs. So for many of our patients, I consider ACE inhibitors or ARBs sort of an essential vitamin, particularly in patients with diabetes. Someone really needs to give me a strong reason, a strong contraindication to use. But most of my patients do leave the hospital with either an ACE inhibitor or an ARB, unless they're allergic or unless they have other reasons such as hyperkalemia or a very borderline renal dysfunction that's hovering on end-stage renal disease that makes me concerned about their safety of using these therapies outside of the hospital. This is generally one of those therapies I initiate pretty early as soon as they're hemodynamically stable. When you look at beta blockers after acute MI and you divide the patients up into those with diabetes and those without diabetes, and it doesn't matter if their diabetes are treated with insulin or not with insulin, this is a retrospective analysis, but it's one of many that seems to show a 1-year benefit in mortality that might be associated with beta blocker use. And that certainly makes sense in someone who already has a diagnosis of diabetes. The study really didn't show much difference. There was no interaction P value that was significant between diabetes and no diabetes. But this is certainly something that we think of as well as a guideline recommended treatment post-acute MI that does not differentiate based on diabetes status, but knowing that diabetic patients have a higher risk of subsequent cardiovascular mortality, this is definitely one of those risk reduction therapies that you should be thinking about. When you're thinking about blood pressure management in patients with diabetes, there are some really great guidelines that are out there. So if you look at this one, these are the 2022 ADA guidelines here. If the blood pressure is above 140 but less than 160, you think about starting one agent. If their blood pressure is greater than 160, you think about 2 or more agents. Look at the middle column. Having CAD an MI counts as CAD, makes you lean heavily towards an ACE or an ARB as your first line of therapy for these patients. But you can also choose from calcium channel blockers or diuretics, particularly if ACEs or ARBs are contraindicated, or as additive therapy if you're not reaching goal with your ACE and ARB. As you continue down that pathway, and this is now someone who is transitioning out of the hospital into clinic, we are monitoring patients' blood pressures very carefully, and especially in the post-MI setting, we often see that blood pressures are either very high or very low during the hospitalization. Once they transition home, start to recover, we do see some blood pressure changes. So in that first visit, post-MI discharge, one of the key things many of us as clinicians pay attention to is what kind of blood pressure are we looking at? Should we be titrating medications to get under better control? And again, we still have that list of ACE, ARB, calcium channel blockers, and diuretics to be thinking about. This is really much more for an outpatient population in the in-hospital post-MI setting. We've got beta blockers in the mix as well. But there are also other things to think about. So you can see the last box on the bottom here is if you're really dealing with refractory hypertension, you could be thinking about mineralocorticoid receptor antagonists such as spironolactone as well. And this is something I often pull out as my third or fourth line drug in patients with refractory hypertension. I see a lot of patients come out on hydralazine. I think this is something that is often easy to reach for in the in-hospital setting. But in the outpatient setting, hydralazine is really not a great therapy for blood pressure management. It's often a TID, 3 times a day medication, if not a 4 times a day medication. So not really quite compatible, at least I know for myself, it's not quite compatible with life. I can barely remember to take my once a day medications, let alone something 3 times a day. So this is often something I see a lot in patients who present to me after their hospitalization. I see hydralazine, and I started looking to replace that with something that's perhaps a little bit easier to take as an outpatient. So many of the drugs that are listed on these on the slide can do the trick here without having to resort to hydralazine. Statin therapy. I don't think there's any data that refutes the benefit of statin therapy in patients with prior ASCVD, and that applies to patients with an MI in the hospital as well. That's the very first box you see here. This is a therapy that has been shown to be quite effective. These are pretty old data from the heart protection study. There have been a lot of recent trials, and one of the more recent ones is ezetimibe. This is on a background of statin therapy, but in patients who might require a little bit more intensive lipid lowering. You can see the grouping of diabetes patients up top. This is the IMPROVE-IT trial. This is a secondary analysis of the IMPROVE-IT trial. You see that benefit of ezetimibe, particularly in the patients with diabetes as opposed to the patients without diabetes. Again, speaking to the fact that this is a high-risk group, and when you're thinking of a treatment that has modest cardiovascular outcomes benefit, and that would probably characterize ezetimibe very well here. This is a high-risk population of patients, these diabetic patients, for whom this therapy can be especially effective in lowering their risk of subsequent death from a cardiovascular cause, MI, or even preventing unstable angina requiring hospitalizations or strokes or downstream coronary revascularizations here. So when you have someone in the hospital setting, I think of ezetimibe when someone comes in already on a statin, their LDL is still not quite where we need it to be. Now we know that there is some instability in LDL levels during an acute MI, but I tend to be pretty European in my LDL appreciation. So if they're, in the outpatient space, I often apply a threshold of 55, US guidelines go 70. So I'm trying to get that LDL as low as possible. So in the in-hospital setting, when someone's already on a statin their LDL is not quite at where they need to be, I intensify that statin to a high intensity statin where I can. And if they're already on a high intensity statin and it looks like they're not going to be able to achieve target, and that's generally a high intensity statin should be able to reduce LDL by another 30 to 50%. And if I think that they're still not going to get to where I think they really should get to, I would think about adding ezetimibe in that setting as well. Keep in mind that the therapies you start in the hospital are very likely to be the therapies that the patients continue on. There's a bit of a therapeutic inertia. If you wait to start as an outpatient, there's a good chance that that therapy doesn't get started, or it gets started quite late. So if the patient is a captive audience, use that time frame to really try to optimize it. There is very little data on in-hospital PCSK9 inhibitor. I think that data should be evolving as we're speaking here. But in the outpatient space, you can see the curves for PCSK9 inhibitors compared with placebo. This is for evolocumab that you see on the slide here. And there's definitely benefit in patients both with and without diabetes. But as you can see on the left-hand side of the slide, the curves diverge fairly early, within a year after starting the therapy, and then continue to diverge over the time. So the number needed to treat there is about 37. So again, this is not just, at least in my practice, I don't think of PCSK9 inhibitor as my first line therapy, but in my diabetic patients, I am very intensive with lipid lowering in these patients. I do pursue that goal of trying to get at least below 70, and ideally, if you want to go by the European guidelines, below 55. So if they are on maximally tolerated statin and they're still not at goal, this is a group of patients that I am happy to fill out the paperwork and to do the teaching in order to be able to get them to take a PCSK9 inhibitor. So there are some other recommendations here. We really, cardiologists don't practice in a vacuum. We need to be coordinating care with the patient's primary care physician. Many of the patients that I discharge from the hospital usually see, we have a follow-up appointment with a cardiologist and with a primary care physician within the next 2 weeks to 4 weeks so that we can tag team this and do modifications. It's not just about medications, it's also counseling about lifestyle modifications, including physical activity, weight management. Cardiac rehab for me is a must in a post-MI patient. So if they have access to cardiac rehab, and nowadays with some virtual cardiac rehab options, there really isn't an excuse for someone not to do cardiac rehab. But I do know that there are some financial barriers to that, but I think that is quite helpful in making sure that the lifestyle modifications you're counseling patients on are sustained over time, and provides another set of eyes to be looking at blood pressure control and lipid management. Here, our cardiac rehab is excellent. I have technicians reaching out to me sometimes, giving me notes about how their heart rate and their blood pressures are behaving while they're exercising, which allows me an opportunity to be able to do some gentle titration of medications in a way that gets them to target blood pressures very quickly here. Metformin is a 2A recommendation. It's often considered the first line of pharmacotherapy and often useful if not contraindicated. We usually wait about 48 hours after contrast exposure to get them back on their metformin, to get them started on their metformin. So sometimes, since the average length of stay is about 2 to 3 days, this is something that we instruct them they would resume or start when after they leave the hospital. And we try to get their A1Cs as close to 7 as possible, and that's a 2B recommendation there as well. A note about cardiologists, it's I'm a cardiologist by training. I see patients in our cardiac intensive care unit and in our regular wards, and I also see many cardiovascular patients in my cardiology clinic. And 10 years ago, I would not have been giving this talk because I always thought that this would have been the domain of someone who I would collaborate with on the primary care side or the endocrine side. But many of us are now on the front lines too. And in part, it's because many of our patients with ASCVD have diabetes. And unfortunately, after they leave the hospital, after an MI, most of them see us in clinic, but very few of these patients will see an endocrinologist. So I think that's one reason why cardiologists are very much on the front lines these days as well. But also because there are some newer therapies that are, quote, for diabetes. They're listed as diabetes drugs, but are really not just diabetes drugs anymore. These are often used for cardiovascular disease prevention, even for renal prevention, and certainly if you're a heart failure doc, these are now considered part of our heart failure regimen as well. So many of these therapies we're starting to get to know very well and know how to manage. I would say that there are still some areas where we do need to make sure we ask for help. So for someone who's on a very complex insulin regimen, I tend not to manage that on my own. That really needs to be done in concert with a diabetes care specialist, whether that person's a primary care physician or an endocrinologist. If there are multiple medications, I often, or if they have an A1C that is quite elevated, I feel much more comfortable getting my endocrinologist involved because these patients really need as many pairs of eyes managing their regimen as much as possible. I get a little nervous when patients have an EGFR that's less than 30. It certainly helps to have a diabetes care specialist involved to help me think about picking medications. And if they have complications of diabetes, such as DKA or hypoglycemia or extensive micro and macrovascular complications, I think this is one of those situations where we want to make sure we've got a great group of specialists that is comprehensively evaluating these patients. So I do involve many of these individuals. Let's talk a little bit about SGLT2 inhibitors and GLP-1s. These are now becoming quite commonly applied in the cardiologist's office. So this is a nice meta-analysis that's looking at SGLT2 inhibitors and its risk of and the MACE associated with that. If you look at the top grouping over here, you can see that in patients with atherosclerotic cardiovascular disease, this is a class of therapy that has definitely been shown to improve risk of major adverse cardiovascular events. So typically CV death, MI, and stroke. In patients without ASCVD, perhaps that benefit is a little less obvious here. The other piece that has really emerged over the last 5 years is the risk of heart failure hospitalization. So diabetes and heart failure actually go together quite often. I would say that more than 50% of our heart failure patients have diabetes. The ratio is a little lower among diabetic patients, but perhaps higher in diabetic patients who are of older age. But in patients with cardiovascular disease, again, in that top clustering of point estimates here, everything's well to the left of the line of unity. So there is a heart failure prevention benefit to the use of SGLT2 inhibitors in these patients. And it doesn't matter if you're thinking about empagliflozin, canagliflozin, or dapagliflozin. All of these are associated with improvements in heart failure in patients with ASCVD, and may also be true in even in the absence of diabetes. So let's see if I can get to the next slide. There you go. So if you look at dapagliflozin, on the left you have diabetes patients. On the right you have patients without diabetes, and you compare dapagliflozin to placebo. You see that the hazard ratio is pretty similar, 0.75. There seems to be benefit even in patients without diabetes, which is why these SGLT2s have really entered the armamentarium for patients with heart failure. This is very interesting. It's certainly an area of a lot of research as we think about, which steps do we take before we start reaching for an SGLT2 inhibitor in patients with heart failure, do we do it before or after we use something like Entresto or spironolactone? But certainly this is a nice addition to our ability to optimize heart failure, and that's often the case in patients who are post-MI. There are a couple of trials that are ongoing right now that are recruiting patients in the acute MI setting to think about when we should be thinking about starting these therapies as well. You know, without, even in all patients, those with and without diabetes, you can look at the A1C measurement. So on the left-hand side, on the x-axis, you see A1C measures going all the way from 5 up to 12. And then the gray set of lines here, you see the 95% confidence interval for the hazard ratio here. And it basically confirms what the previous slide shows, which is the amount of glycemic control doesn't matter in both heart failure patients and in both diabetes patients and patients without diabetes. We do see a benefit to using SGLT2. People often wonder about adverse events, particularly the non-diabetic patients are either hypoglycemic or other events that could cause a study drug discontinuation. And this trial really showed that there was no significant difference in the patients treated with placebo or DAPA. If you look at the second row, this is the no diabetes group. It's 4.5% versus 5.3%, numerically slightly higher in the DAPA group, but again, not reaching statistical significance here as well. So again, lots of research being done about how we implement drugs like dapagliflozin in patients without diabetes, but who are at risk of heart failure here. And then finally, we'll talk a little bit about the impact of renal disease. And again, in patients with atherosclerotic cardiovascular disease, this slide is very much like the other slides. There's benefit. We can slow down progression to end-stage renal disease in these patients. And that may also be true in patients even without cardiovascular risk factors as well. As you can see in the CAMAS program and the DECLARE program, there seems to be a hint for renal protection even in the absence of ASCVD here as well. So I think the nephrologists are getting as excited as the cardiologists and the heart failure docs about the use of this therapy in patients with chronic kidney disease. Let's spend a minute and talk about GLP-1 receptor agonists. These tend to be mostly injectables, although there are some oral forms available. There does seem to be a protective effect as you think about major adverse cardiovascular effects. This is the meta-analysis here, where you've got a hazard ratio of 0.88, a number needed to treat of 75. For cardiovascular death, again, you do seem to see some benefit here for this class of therapies here, again with a hazard ratio of 0.88, but a slightly higher number needed to treat here. The confidence intervals are a little bit wider because this is a rare event here. So also something to think about, and I tend to think a little bit about GLP-1 receptor agonists, particularly in patients with a high BMI, because many of these therapies do have a BMI lowering benefit as well associated with that. I will confess this is not an easy class of medication for me to reach for, in part because it is mostly an injectable, whereas SGLT2s are orals. So something I would say that me personally, I tend to reach for SGLT1s, SGLT2s a little bit easier, faster. And so I think that's also the reality. On the left-hand side, you've got the algorithm that is put out by the professional societies here. But which class for which patients? I think the reality is many of our cardiologists are going to think about an SGLT2 inhibitor first because this is something that they're comfortable with. We know that 14 to 36% of MI patients ultimately will develop heart failure. And so as a class of therapy that tends to reduce heart failure hospitalization, this is something that could have benefit in that. Half of these patients also have ASCVD, also have CKD, and so trying to slow down progression to renal failure is something that is very attractive there as well. Other attractive features, it's oral. It's much easier to think about teaching someone to use if they've never been on an injectable before. These are once a day dosing. There's really not a whole lot of dose titration that goes on, and not a lot of monitoring that needs to be done other than glycemic monitoring. Although there are some side effects that really need to be known about these therapies, particularly the risk of fungal infections in these people. So the things that I generally think about when I start this class of therapies, the blood pressure does tend to go down. In part, there's a diuretic effect for the SGLT2 inhibitors. It can also reduce the A1C by a little bit. It can reduce weight also a little bit, but there is a 3- to 4-fold risk of fungal infections, and some people could get orthostatic symptoms from the initiation of these therapies, as well as an uncommon but clearly dangerous risk of euglycemic DKA. So things we think about most, I think in the early days of me using these therapies, I often, would CC the primary care physician to say, hey, this is a therapy that I'm starting here. I'm going to see the patient back a little bit earlier. It would be great if you could also see the patient back a little earlier as well, just so that we're keeping an eye out for these therapies here. I don't talk about genital hygiene too much in my clinic, but I do tell people that there is a risk of UTIs and vaginal infections in my female patients, so I ask them to watch for that. I do ask them to monitor the diabetic patients, to monitor their blood pressure and their blood sugars at least a little bit more intensively in the first 2 weeks starting these therapies here. Other things as cardiologists we need to know, we do have to think about this a little bit more carefully in patients who previously had DKA or in patients who have renal dysfunction. And so these are patients I still make sure that I talk to my the patient's primary care physicians about when I start, just to give them a heads up about that. This may also require some insulin dosing adjustments if needed to. When I see patients in the hospital, they're on an SGLT2, I make it a routine practice to just pause SGLT2 at least in the first 24 hours until I get a better handle on what's going on. I don't think there's any downside to stopping those therapies for a day or two. And then we're watching for that euglycemic DKA as well, particularly when someone's in critical care. So let's go back to our case. Just to quickly remind you, this is a gentleman who, a slightly older gentleman, type 2 diabetes for a while now, hypertension, now just got an LAD stent, has a history of pancreatitis. What are some of the things we're thinking about for this person? His GFR is okay at 69. So this is someone, cardiac things first. We would make sure we have adequate stent protection and cardiovascular risk reduction. So aspirin and dual antiplatelet therapy with aspirin is pretty key in this patient. So either clopidogrel or ticagrelor for this patient. I tend to use a little less prasugrel in the population who are 75 years of age or older. This is someone I would switch their atorvastatin to switch their dosing or their statin to a higher intensity. So that would be atorvastatin 40 or 80 or rosuvastatin 20 or 40. Just to make sure that, and this person's LDL was still a little on the high side. So if there's an opportunity to intensify the statin, I do. If there's not much of an opportunity to intensify the statin, this is someone I would think about ezetimibe for. They are already on an ACE inhibitor for diabetes primary prevention. I would think about adding a beta blocker, mostly trying to target blood pressures in the lower than 130/85. 2 days after their cath, I would have them resume their metformin. Thinking about an SGLT2 versus a GLP-1 receptor agonist, I would favor the SGLT2 inhibitor, in part because the GLP-1 receptor agonist does have some concern in patients who previously had pancreatitis, so I tend to stay away from that class of therapies in someone who's had prior pancreatitis before. I strongly counsel this patient to attend cardiac rehab. We set a weight goal for the cardiac rehab as well as an exercise goal that they should reach eventually from a lifestyle modification standpoint. And then I make sure that this is a patient who leaves the hospital with an appointment in hand So for example, if it's a Friday and they're discharging over the weekend, I call and get the appointment Friday afternoon before the office is closed, because this is someone who's going to need very careful follow-up, definitely not someone who's going to you want to let fall through the cracks here. And since their EF is 40%, it might be worth getting another echocardiogram down the road, maybe about 6 to 8 weeks, to make sure that there is some EF recovery. If not, we may be thinking about other therapies that could help reduce the cardiovascular risk, such as an ICD. So this is a bit of a whirlwind tour of what I tend to think about when I'm treating patients in the hospital with acute MI who have diabetes. There was a very, very nice recently published scientific statement looking at talking about management of cardiovascular risk factors for adults with type 2 diabetes, that if you have a chance to read, you should. I put the scientific statement on the slide, and our staff can also circulate that PDF of that if interested. So I want to thank you all very much for listening to us, and I'm going to turn it back over to Renee.
Thank you so much, Dr. Wang, for that wonderful presentation, and really emphasizing the opportunity that we have for immediate and long-term impact while these patients are in the hospital. As a reminder, you can submit questions at any time in the questions pane. I see some are coming in, and we'll review them in just a few minutes after we review some of the changes that we've made and get with the Guidelines CAD. I'd now like to turn the presentation over to my colleague, Jeannie Rash. Jeannie, the floor is yours, and you can advance the slide. Thank you.
Great, thanks, Renee. I'm waiting to advance the slide. You may need to assist me with that.
Okay. Should be able to go ahead. The first one takes just a moment. So if you click next.
I'm not having any luck, Renee. Sorry.
Oh, that's okay. I'll go ahead and advance for you. Go ahead.
Okay. So good afternoon, everyone. Sorry for that slight delay. I'll be brief here. I wanted to review with you the changes that we've actually done to the Get With the Guideline CAD registry that aligns with all the information that was just presented to you. As mentioned at the start of the webinar, the changes to the registry actually occurred back in December. So you should have access to the changes that are on the data collection form, and also the new measures that are available to you. There should be some written release notes about these updates in the library of online resources within the registry. Next slide, please. So just a couple of updates to the data collection here. There are two of them on the pre-hospital arrival tab. One of them is in the medical history section that provides some added detail to the type of diabetes that's in the patient's medical history. And for those patients who come into the hospital who don't have a previous medical history of diabetes, but are newly diagnosed during the episode of care, their status can be documented in a new element, the new diagnosis during this admission. Next slide, please. And then there's one additional update on the discharge tab in the discharge medication section, and that's a few elements for recording any anti-hyperglycemic medication that was prescribed at discharge. There are up to 4 different classes and medications that can be recorded here. If you're unfamiliar with the medication classes, there is a table within the coding instructions that will indicate which class certain medications belong to. And if an SGLT2 inhibitor was not prescribed during this episode of care, for there will be an additional message asking, was there a documented reason? This will give us all opportunity to assess some of the risk reduction treatments that are being prescribed, and allow us to calculate new measures that have been added into the tool. Next slide. So the measure sets that have been added will probably look somewhat familiar to you. A lot of these are already in the Guidelines-CAD registry. Many of these measures have been adapted specifically for patients with diabetes. So although it is a similar risk reduction measurement, we are focusing strictly on the diabetic patients. So those are patients with either medical history or newly diagnosed. And then something to also note here is unlike our other Get With the Guideline measures that are separated by STEMI and NSTEMI populations, for the diabetes measures, all AMIs are included. So you'll see it's for AMIs. And then we have a composite measure that is an accumulation of all those measures. And we have one reporting measure that's looking at the anti-hyperglycemic medication with the proven CVD benefit that Dr. Wang was just reviewing. Next slide. So this is just meant to illustrate, again, the difference in the patient population. So the initial population could be a STEMI yes or STEMI no, but there would be positive cardio biomarkers indicating an AMI. So those patients would be included, and then the medical history or new diagnosis of diabetes. So this is for the 9 measures that are looking at the risk reduction therapies, and the population for the reporting measure for the SGLT2 medication is outlined on the next screen, and that is slightly different. It also includes both types of MIs, but we're looking at the diabetes type of type 2 only for this metric. These full measure description documents are available to you in the library of online resources, so you can take a closer look at those to better understand exactly how the measures are being calculated.
Thank you, Jeannie. And I just want to take one moment so that we could have a time for questions, just to share with everyone this roadmap for including these for these diabetes measures. This was also shared back in December, and just want to emphasize that 2022 awards that are based on 2021 calendar year data will not be impacted by these changes. And you can see here in the roadmap, we started data collection in late December, and this is the time all of the CAD hospitals have access to these data elements and reports that Jeannie just reviewed, and we will take time during 2022 for our national volunteer committees to review and analyze the data that's coming in, and then make a decision if it's appropriate or not to update the target type 2 diabetes honor roll awards for the next round of awards in 2023. And I know we're at the top of the hour, but Dr. Wang, I just wanted to bring up one question that came up from the audience. Are non-diabetic patients generally reluctant to start SGLT2s in your clinical practice? If so, are there general education points you discuss with them to encourage starting them? Also, is it becoming more common practice for you to prescribe, discuss this class of meds in your practice?
Yeah, very good question. There actually I have not encountered resistance to thinking about SGLT2 inhibitors in non-diabetic patients in my practice, in part because, this is a little tongue-in-cheek, but people don't always know that this is a drug that was originally developed for diabetes. I think the biggest resistance to these therapies is often in the form of cost. None of these therapies are generic just yet. There are no generic SGLT2 inhibitors yet. So this is often a therapy that can cost a bit in terms of out-of-pocket costs for co-payments and things like that. This may especially be true in patients who are also on another non-generic heart failure medication. So things like sacubitril, valsartan, or Entresto is also not generic yet. And so I think the cost piece, I think, is probably one of the bigger barriers to be thinking about when we're starting these therapies. And we hope that that's actually a situation that'll change a little bit once the evidence base for these therapies build up a little bit more. But yeah, the short answer is, you know, non-diabetes versus diabetes, there's not a whole lot of resistance to starting these. These are conversations we're now starting to have a lot in our clinic. I would say in the majority, I'd say out of 5 patients that I start an SGLT2 inhibitor on, 4 of them are probably diabetic. And then the final piece of things I would say is, you know, because SGLT2 is an oral drug, in many ways patients think of it very similar to many of the other oral drugs that they're taking, like ACE inhibitors, beta blockers, and spironolactone.
Thank you, Dr. Wang, and thank you to everyone for submitting your questions. We will review those that we didn't have a chance to answer, and I want to thank everyone for staying on a couple minutes past the hour. So thank you also, Jeannie Rash, for being part of today's webinar, and for all of you, all of your participation. Just a reminder, after today's event ends, you will receive a follow-up email with the survey on the presentation, and you'll also receive a recording of from today. This concludes our today's presentation. Thank you so much, and have a wonderful afternoon.